endotracheal intubation, nasal. The equipment required for this procedure includes a cardiac monitor with SpO2 and end-tidal CO2 readouts, oxygenation and ventilation devices including BVM, filter, and tube extender, suction, and a nasal ET tube. All of the equipment that you require for the procedure should be laid out in advance and readily at hand. Full PPE, including mask, goggles, and face shield, are required to be worn for this invasive procedure. Indications for nasal endotracheal intubation include a need for ventilatory assistance or airway control, and other airway management is inadequate or ineffective. Unlike oral ETI, nasal intubation is contraindicated in patients presenting with suspected basilar, skull, or midfacial fractures, uncontrolled nosebleed, on anticoagulant therapy, excluding ASA, or bleeding disorders. While performing the procedure, there is a period of time where the patient will not be ventilated or oxygenated, during which the patient's oxygen saturation will drop steadily, so before attempting to nasally intubate the patient, you'll need to pre-oxygenate them as close to 100% SpO2 as possible, approximately 30 to 60 seconds, using a BVM with end-tidal filter attached to the mask. Next, prepare each nair with sprays of xylometazoline and lidocaine. Both nairs should be prepped regardless of which you eventually use to insert the nasal ET. Then reapply oxygen while you prepare the nasal ET. Select an ET tube appropriate for the size of the patient. Typically, tube sizes will range from size 6.0 millimeters for a small or female adult to an 8.0 millimeter for a large or male adult. Next, lubricate the inferior end of the tube, including all of the cuff, with a water-based lubricant using the inside of the sterile packing that the tube was in. Advance the tube with the bevel to the septum of the left nair with an advancement angle 90 degrees to the plane of the face into the nasopharynx. Continue to advance slowly while listening for sounds of the patient's breathing and manipulating the thyroid cartilage into the burp position. As the patient inhales, the vocal cords are open and the tube should advance with little resistance, while the back upright position will help to bring the patient's glottic opening into better alignment with the tip of the advancing tube. Once the tube is in place, begin the initial assessment of tube placement confirmation by listening for air movement and looking for misting in the tube. To confirm placement, attach the BVM, with or without a tube extender, and ET CO2. Record the end-tidal value and look for a noticeable 4-point waveform on the monitor display. Inflate the cuff of the tube and auscultate for placement and cuff leaks as you would an oral ETT. Once the placement is confirmed by these methods, secure the tube in place with the method utilized in your service.